Hello. I'd like to welcome you to this segment of Beaumont Hospital's seminar on the multidisciplinary care of reflux. My name is Daniel Rontal. I'm a practicing otolaryngologist, and I'm the director of the Center for Reflux and Esophageal Cancer Prevention at Beaumont Hospital. The title of this talk is Laryngopharyngeal Reflux. I'll be touching on a few areas in particular. These include the definition of laryngopharyngeal reflux, the symptoms of laryngopharyngeal reflux, how laryngopharyngeal reflux is different from gastroesophageal reflux, how laryngopharyngeal reflux is diagnosed and treated, and finally the complications of laryngopharyngeal reflux. So first, what is LPR? Reflux literally means backflow. In this case, it's the backwards flow of stomach contents into the esophagus and higher to the level of the throat. This slurry contains acids, digestive enzymes, and occasionally bile. Gastroesophageal reflux is when these stomach juices back up into the esophagus, whereas LPR is when the flow goes even higher to the level of the larynx and the pharynx. These two are related diseases. They share many of the same characteristics and can occur together, but as you will see later, they are distinct entities. LPR symptoms are more subtle and vague than those of GERD, and typically the symptoms include frequent throat clearing, a lump sensation in the throat, a dry chronic cough, postnasal drip, hoarseness, and rarely even nocturnal laryngospasm. What you don't hear me talking about here is what most people think of when they hear about reflux, and that's heartburn. Only about 40% of patients with LPR will have symptoms of heartburn. In other words, more than half of LPR sufferers will not have the classic symptom associated with reflux, and therefore are unlikely to think of their symptoms as being related to reflux. This can create difficulty with diagnosis, as well as difficulty accepting the intensive treatment required for this disease. Here, on this somewhat busy slide, is a side-by-side comparison of GERD and LPR. You can see that the diseases are quite distinct. A few highlights include the heartburn question that I've already discussed, the fact that LPR sufferers reflux typically during the day and in an upright position, whereas GERD patients typically reflux while supine and at night. Esophagitis is unusual for LPR patients, and they respond more slowly to acid reduction medications than GERD patients. Feel free to pause the lecture here and peruse the full list of differences. The symptoms and damage from LPR are caused by two main sources, acid and the digestive enzyme pepsin. The acid, in the form of hydrochloric acid, is produced in the stomach. The larynx is far less hardy than the esophagus in terms of its ability to resist the damage from acid, and in fact as little as 4 seconds of acid exposure per day can lead to the symptoms of LPR. Pepsin, likewise, is more damaging to the larynx than the esophagus. Pepsin is most active around a pH of 4, but it is still weakly active up to a pH of 5.5. Pepsin is phagocytosed into the cells of the larynx, and when it reaches the Golgi apparatus where the pH is around 5, these cells can be autodigested. Pepsin exposure also decreases the larynx production of carbonic anhydrase 3, and this further weakens the resistance to acid. The diagnosis of LPR centers on three things: a targeted history, physical examination, and specialized testing. History is used to establish both the symptoms of LPR as well as to ascertain whether or not other diagnoses could be contributing, such as allergies or sinusitis. Furthermore, careful history may point towards danger signs for complications, such as laryngeal or esophageal cancer. Crucial to the history, and often overlooked, is an understanding of the patient's dietary habits, when they eat and what they eat. You will see the particulars in a few slides. Physical examination includes a comprehensive head and neck exam, and again is used to find signs consistent with LPR and rule out other pathology. Some other medical conditions to look for are infection, including sinusitis and pharyngitis, allergy, thrush, and mass lesions. The most helpful specialized test for LPR is flexible fiber optic laryngoscopy. This gives an unparalleled view of the larynx and pharynx both at rest and in motion. I will show a few representative images of LPR changes later on in a few slides. Another helpful adjunct is pharyngeal pH testing, which can help establish the diagnosis in complicated cases, as well as determine whether treatment has been effective. Swallow tests have poor sensitivity for LPR, but can show other causes of dysphagia, as well as occasionally diagnosing complications in the esophagus. Displayed here is a schematic representation of a flexible fiber optic laryngoscopy. A flexible scope is passed through the nose after topical anesthetic spray is applied. This is usually very well tolerated, even amongst the most anxious patients, including children. Next is an example of the view achieved with fiber optic laryngoscopy. You can see the crisp white true vocal cords, the false vocal cords, and the laryngeal ventricle between the true and false vocal cords. Also shown here are the anterior commissure at the front of the larynx and the posterior commissure at the back. I look for a few different signs in the larynx of patients with reflux, and these include swelling along the inferior surface of the true vocal cords, inflammation in the posterior aspect of the larynx, obliteration of the laryngeal ventricle with edema, and changes to the texture of the mucosa of the larynx, specifically the mucosa between the arytenoid cartilages. Obviously, it's important to also look for mass lesions on this exam. Shown here is an image of the larynx of a patient with LPR. Here we see the most common sign of LPR, called pseudosulcus, or infraglottic edema. You can see there is swelling below the vocal cords, which shows here as a pale purple strip that extends from the anterior commissure to behind the arytenoid cartilage. Approximately 70% of patients with LPR will have pseudosulcus. Next is the larynx of another patient with LPR. In this case, the posterior aspect of the larynx is swollen and red. The esophageal inlet is just behind the larynx, and therefore when reflux comes up, the posterior aspect of the larynx typically sustains the worst of the burn. This final laryngoscopy image shows swelling in the posterior portion of the larynx, specifically in the space between the arytenoids. Here the mucosa is not red, but rather pale with a cobblestone appearance. We call this interarytenoid pachydermia. The next type of testing I would like to discuss is pharyngeal pH testing. Most physicians are familiar with esophageal pH testing, whether via catheter or capsular probe, and pharyngeal pH testing is similar. As we discussed earlier, the pharynx and larynx are not as well suited to acid exposure. pH levels in the 5 to 5.5 range are damaging to the pharynx and larynx, whereas the esophagus tolerates this reasonably well. Currently, there is one pharyngeal probe on the market. It is a catheter-based probe and is inserted through the nose without anesthesia. Visual confirmation of the probe location is through a red blinking light seen in the throat. It is worn for 24 hours, and patients are to eat and drink their normal diet and go about their normal daily activities. The data is presented as a graph of the pharyngeal pH. This here is a graph of the pH of a patient with LPR. As you can see, the pH drops significantly for this patient, well below the harmful levels of 5.5. Some of these spikes of acid exposure are after a meal, while others are prolonged bathing of the pharynx with acid while the patient sleeps. Now I'll move away from diagnosis to treatment. Treatment of LPR is similar to that of GERD. The treatment, however, is typically more intense and of a longer duration. The three tenets of treatment are lifestyle modifications, medications, and surgery. The first part of treatment is lifestyle modifications, and what we're primarily talking about here is eating. In terms of the timing of meals, I recommend patients not eat for about 3 hours before going to bed. This gives the stomach a chance to empty before lying down. If you lie down with a full stomach, gravity can't help keep the food down in the stomach, and there is a greater chance of stomach contents coming back up. The second part of lifestyle modifications is the choice of foods that we eat. Some foods are particularly problematic for reflux. The first group here is those containing methylxanthines, such as caffeine. This includes coffee, tea, and chocolate. Methylxanthines relax the valve at the top of the stomach, the lower esophageal sphincter, and allow the stomach contents to reflux upwards. Unfortunately, decaf coffee and tea is not much better, and many herbal and green teas are also a problem. Mint and alcohol also relax the LES. Soda distends the stomach, pushing the contents back into the esophagus. Spicy foods as well as acidic foods such as citrus, tomato, pineapple, and vinegar directly irritate and injure the tissues. Finally, fatty foods delay the emptying of the stomach, allowing more time for its contents to back up into the esophagus and throat. A low reflux diet limits these foods as much as possible, and eliminating these foods can dramatically impact a patient's reflux. The next major category of treatment for LPR is medications. These do not reduce the actual reflux of stomach contents, but rather reduce the acidity of what washes up. Antacids have been known about since the 1st century AD, when Pliny the Elder ground up coral to be ingested as a treatment for heartburn. The coral powder was high in calcium carbonate, which is still used in antacids today. Flash forward to the 1970s when Tagamet was introduced as the first H2 blocker, and it started the next phase of medical treatment for reflux. These first two, however, are not thought to be strong enough for LPR, and as a mainstay, a group of medications called proton pump inhibitors is used. Discovered in 1979, omeprazole became the first in a new class of medications to directly target the acid production pumps in the stomach. Since omeprazole was introduced under the brand name Prilosec, many other drugs have been added to this class of medications, improving the efficacy and extending the duration of acid suppression. Again, even the strongest PPIs do not stop the actual reflux. They only reduce the acidity. Treatment with PPIs in LPR is far more intense than what is used for GERD. Typically, these require twice daily dosing, and an average course of treatment is 4 to 6 months. Occasionally, other medications are necessary. Promotility agents such as metoclopramide and cytoprotective medications such as sucralfate are occasionally helpful, especially in those patients with bilious reflux. The general goal is to have the shortest possible treatment course and avoid the long-term side effects of PPIs such as osteoporosis. The final tenet of treatment for LPR is surgery. Surgery is usually reserved for the most severe patients. These are patients who are not controlled on medication or those who can only be controlled on the highest dosages of medication. The other group of patients to pay particular attention to are the young. These people may potentially be facing decades of expensive medicines with their associated risks and side effects, and in that sense, the risk of surgery may be less than the risk of long-term medical therapy. The standard surgical procedure is the Nissen fundoplication. This is typically performed laparoscopically, and the details of this surgery will be discussed elsewhere in this symposium. The goal of surgery is to make patients symptom-free without the need for further medications. The idea behind the Nissen fundoplication is to tighten the lower esophageal sphincter by wrapping the top portion of the stomach around the lower portion of the esophagus. Again, the details of this can be seen in another lecture. Reflux can lead to serious complications, some of which can be life-threatening. Some warning signs for potential complications include progressive dysphagia, pain, coughing up blood, worsening hoarseness, and weight loss. Treatment for LPR can help improve patients' quality of life, but we also aim to prevent some of the drastic complications that can occur with reflux. This list is by no means complete, but does highlight some of the most devastating complications. Some might think that because the symptoms of LPR are centered in the throat, that the esophagus is spared. Not true. Esophageal cancer is certainly a risk with LPR, and in fact, LPR symptoms correlate better with the diagnosis of esophageal cancer than those commonly attributed to GERD. LPR is also a cofactor in the development of laryngeal cancer, especially among non-smokers. Some series show that a history of LPR is more common in those patients who develop laryngeal cancer than even a history of smoking. Laryngeal granulomas, regardless of their etiology, are often persistent due to the chronic inflammation from LPR. Treatment of granulomas is frequently unsuccessful unless patients are treated with proton pump inhibitors. Airway stenosis, such as this subglottic stenosis, are devastating problems. Reflux is involved in the development of many of these stenoses, and successful surgical treatment frequently requires long-term acid suppression. Our feeling at Beaumont is that bringing together all of the specialties that are affected by LPR can help in the management of this complex disease. Having all of the stakeholders together results in a unified, interdisciplinary plan for both the evaluation and the treatment of laryngopharyngeal reflux. Our goal is to reduce the incidence and severity of reflux complication through early diagnosis. We attempt to streamline the evaluation for reflux to decrease the overall cost as well as speed the time to resolution. Finally, we aim to find the most efficacious treatment for each individual patient while minimizing the risk of complications and side effects. In summary, LPR is related to GERD, but it is truly a separate disease. Its symptoms are somewhat vague and overlap with other disease states. Examination and specialized testing results in accurate diagnosis of LPR in the majority of cases. The treatment of LPR is often more intense than the treatment of GERD. Non-medical, medical, and surgical modalities all have a role in the treatment of LPR. And finally, if left untreated, LPR may lead to devastating complications. Thank you for your attention. And if you have not already, please feel free to view the other lectures in this symposium.